Hi again, welcome back. Today we're going to talk about therapeutic misconception. I think this is a topic that you should be able to probably identify with rather easily, whether you realize it or not at this point, but I think everybody has some degree of therapeutic misconception that happens in the healthcare setting. So some of this might be very identifiable for you. I know it is for me. So let's talk about first, what is therapeutic misconception? And for brevity's sake, I'm going to refer to that on all of the slides as TM. Your textbook describes it as the mistaken belief that decisions about one's treatment while a research subject should be made solely on one's individual conditions and needs. So remember, we talked about earlier in the semester, what is the difference between clinical research and medical care? In other words, TM is confusion on the part of the participant regarding the goals of clinical trials. So if you've been going to a physician, different physicians throughout your life, you become aware that the decisions about your treatment are based individually on your needs. You can see why this can be very confusing about people participating in a clinical trial understanding the goals of that trial. Your book talks about two types of therapeutic misconception. The first one, which they refer to as TM1, is failure to differentiate between the goals of medical care and clinical research, which I just mentioned. Also, therapeutic misconception 2 is an appreciation of the standardized care that is inherent in clinical research, but unreasonable expectations and assumptions of individual benefits. So in TM1, an individual just doesn't understand what clinical research is attempting to accomplish. Whereas in therapeutic misconception type 2, that individual participant understands that this is clinical research, but they almost have a confirmation bias almost that they are going to get benefit from participating in clinical trial. So that's a little bit grayer. This is going to be the trickier type to sort of deal with. In TM1, you could simply explain the difference between medical research and medical care and clinical research. But in TM2, you're going to have to really sort of dig deep with that individual to hopefully explain to them that there is no reasonable expectation of benefit. So what are some of the root causes of therapeutic misconceptions? And there's a lot of them. And this is by no means an exhaustive list. You could find other root causes for therapeutic misconception, but we're going to talk about sort of the big, obvious ones. In the first one, subjects assume that physicians' focus on the patient's best interests will follow into the research setting. This can be evident if a patient sees a physician for care. I have an example. I see a pulmonologist. She also performs clinical research in her practice. So I've never participated in clinical research with her, but if I were to enroll in one of her clinical trials, I could become very confused that she is no longer looking out for my individual needs. Another one, subjects don't understand the concept of randomization in randomization trials. Obviously, this doesn't apply to other study designs. And so sometimes people don't understand. They might read that people are going to be randomized to Arm A or Arm B or Group 1 and Group 2, but they get very confused and they don't really understand what that means to them. They sometimes think that's going to happen to somebody else. Sometimes subjects don't understand the implication of strict protocols required during trials. And this would help, if they understood this would help them to sort of clarify and get a better perspective on the fact that protocols are written in a standardized fashion to create and generate data. And that might help sort of clarify the difference between clinical research and medical care. This one I think we can all identify with. Subjects have an overwhelming psychological need to believe that participation will yield personal benefits, right? That bias. You know, I buy lottery tickets, not very often, but every once in a while I'll buy usually when I'm on vacation, I will buy a lottery ticket. I will buy a lottery ticket, especially if I'm out of state, because I think it would be extra fun to win money. I don't know why. It makes no sense, but it's just sort of a little thing I do. And you know, when I buy that lottery ticket, I think I am the lucky one. I am going to win this Georgia Powerball lottery tomorrow night. And of course I never have. You would not be listening to this lecture if I had won a lot of money. But you know, everyone wants to believe that they are going to get this personal benefit. So in the clinical research setting, we are trying to investigate whether something is efficacious. And so there's a chance that's efficacious, and people are very likely to believe that value and that benefit is going to apply to them. Also, subjects may demonstrate acquiescence or social desirability in the presence of physicians. Sometimes, and we'll talk about sort of who's more at risk for therapeutic misconception, but older individuals oftentimes want to make their physician happy, and they also believe that their physician knows best. And then sometimes there's just communication problems between the clinical research site and the patients. For example, what is an arm? Is it those two things that attach to you at the shoulder? No, not in a study design, it isn't. So when we talk about, you could explain to a patient that they're going to be randomized to arm A or arm B. That might be really confusing right there, but you would be very comfortable using those words. Placebo, double blind. Double blind, you think blind is bad, double blind's horrible. No, you know, again, back to the research lingo that we use. Randomization. So sometimes we talk to participants in jargon that they don't understand. So you do have to be very careful about that. More site miscommunication. This is actually taken from a Cancer Care Centers of South Texas in 2009 had this on their website under FAQs. This site is no longer active, so you can't find this any longer, but this actually is what it said on their website. Why do patients participate in clinical trials? Some cancer patients may participate because they are hoping for a possible cure and longer life or a way to feel better. Well, that's true. That is what they're hoping for. But that is perhaps a but misleading to individuals. If other people are hoping for a cure and longer life or way to feel better, well, that's what I would expect too. So this is a bit misleading. I also found another website which is no longer functional as well. The National Cancer Institute in 2008, should I take part in clinical trial online FAQs? The question, what are the potential risks and benefits of clinical trials? And the language here, potential benefits include health care provided by leading physicians in the field of cancer research. This is true. Those are physicians. They are, by participating in an NCI study, they're most likely leading physicians in their field. And now this gets really confusing here. You are getting clinical research care, not really health care, because before we said medical care or health care is individualized for that participant, for that individual patient. Clinical research is not. So this right here is very confusing. Now, part of the reason that these websites, these pages are no longer active really is because they are misleading and they have been updated, they have been improved. But you can see where site miscommunication can really create a lot of confusion for people participating. So the central ethical question of the therapeutic misconception really is the consent process valid in an individual who experiences therapeutic misconception? Because this is going back to the question about autonomy, and that autonomy and that self-agency which allows individuals to make the best decision for themselves is based and it is dependent upon knowledge. And without the knowledge necessary to make a good decision, then you really don't have autonomy. So this question really gets to be important, but this is not an easy question to answer. The first part is, how do we even assess therapeutic misconception? When you talk to a participant who's about to sign a consent to participate in a clinical trial, you can talk to them and you can ask them questions and assess their understanding in sort of a fluid manner. But there are no validated tools out there to really assess therapeutic misconception. How do we define a therapeutic misconception threshold? So in other words, what is a passing grade someone would need to earn in order to make that research site comfortable that they are functioning from a really good place of understanding in terms of therapeutic misconception? And then, is the risk to benefit ratio and overall safety assessment by the IRB sufficient enough? You know, all research sites really trust the IRB to be making very good decisions, because the IRB is really designed to be a patient advocacy group, right? The only thing the IRB is worried about is the patient being treated ethically. But we have to ask ourselves these questions as clinical research coordinators, because the IRB is staffed and run by humans. And so you would be doing yourself and your participants a disservice simply by trusting the IRB at everything that they say. So you have to be aware as a clinical research coordinator, you have to be aware of all of these kinds of questions and these considerations, so that you are also working from a position of taking the best ethical care of that participant. So what are some therapeutic misconception associated characteristics? So there are some things that researchers have found will increase the likelihood that therapeutic misconception exists in a participant. Lower level of education. And this oftentimes can do with how the consent form is written and how information is given to a participant. The lower the level of education, the more likely there will be difficulty in understanding some key things. We will talk about vulnerable patients here shortly, and we'll talk about educational levels. Increased age. Remember, we said about acquiescence and social desirability of the physician and a favorable relationship with the physician. Older individuals still oftentimes, and you might experience this in your own family, and I've seen this lots of times, the physician knows best, sort of still functioning under that paternalistic model. Greater illness severity. So that therapeutic misconception where you believe that you are going to get the benefit is more likely to exist in someone who is severely ill, because think about it, they really need benefit, and so it is likely that they are believing that they're going to get benefit. Studies with the risk of death. If you are going to participate in a study where death is a possible risk, you really have to be able to believe in your heart that you are going to get benefit, to be able to justify to yourself why you are participating. So this can go hand in hand with greater illness severity. If I had cancer and the risk of death was a risk involved in the study, I might still be likely to go ahead with the belief that I'm going to get benefit. Standard treatment failure, also cancer example again. If I have failed multiple different types of chemotherapy, I am more likely to be getting a little bit desperate and more likely to believe in therapeutic misconception or experience it. Also, absence of alternative treatments. There are still lots of diseases out there that don't have like maybe one good treatment option, and if you fail that, you really don't have any other treatment options, and that might increase the likelihood of DM. So some possible solutions. Educating investigators. Now, investigators are smart people. They have very high levels of education and experience often. And so when we talk about investigator education, it's not just making them more aware, because they understand the study design, they understand the risks, they're very capable of talking to participants, but educating them about therapeutic misconceptions so they can be aware of it, so they can look for it. So talking to them about TM. IRB education also, again, not about the study so much and the clinical research and the scientific methods, but about therapeutic misconception. Patient education. Now this one I like. Use of a neutral patient educator. Those first three are pretty obvious. Making people more aware will increase the likelihood that you can address it. Now, use of a neutral patient educator would be, I think, really a great idea. This costs money, so this is going to be less favorably viewed by a lot of research sites, but it would very much help that patient education portion. So having someone who's neutral, right, who doesn't have a vested interest in recruiting for that trial, and really is just a person focused on that individual participant. Ooh, this one's very controversial. Reduced information in consent forms. If you haven't participated in an internship yet, you will find that clinical research consent forms are very long. Everyone, well, not everyone, but most people have signed a consent form in the course of regular medical care. If you're going to have some wisdom teeth out at the dentist, for example, they'll have you sign a consent form. It's usually a page, maybe 2 pages long. Clinical research consent forms typically run 10 pages, upwards of 20 pages. In an effort to make sure we respect autonomy, consent forms have gotten longer and longer and longer because you make sure you have not missed anything. So, long consent forms are very tedious to read. And one theory is that if you reduce the information in the consent form, you will be able to better hone in on the key points that the patient and that participant needs to know. So I like this. It will be a difficult sell with most IRBs and most study sponsors. Patient questionnaires to assess what they understand. The thing about patient questionnaires is you could assess someone's level of therapeutic misconception to some degree. Remember, we said we don't have a good validated tool, but you could use a questionnaire to assess their level of understanding. But I will tell you, it will change with time. Therapeutic misconception is not a, you got a 80% on this quiz and that is your grade. This is more like something that's fluid and changes. So what someone understands in the consent form one day will change a week later or a month later. So the patient questionnaires, if they are considered as a possible solution, have to be introduced throughout participation in the clinical trial. And then significant financial incentives for participating. Now, we're going to talk a little bit in the next lecture about patient recruitment, depending on which order you watch the lectures. So we talk about incentives being fair so as to respect the principle of justice. But if you give someone a lot of money, more than usual, to participate, the theory, the idea here is that you would make them more aware that they are a research participant as opposed to a patient. So emphasizing that they are participating in clinical research by paying them, because patients don't get paid. Now, if you give a participant a cab fare voucher or subway tokens or wherever you work, that could be very much misconstrued, right? Because I am, as a patient, when I go to my pulmonologist's office, they validate my parking ticket for the parking garage. So if you add incentives that are really obviously significant and really stand out to that participant, they will know and they will be more self-identified as a clinical research participant. So some dimensions of research that should be understood by trial participants, and this would help us to further discuss reducing the length of those consent forms. And you'll see this in the attachment in the module. Dimension 1 is scientific purpose, right? Clinical research is to produce knowledge, and getting people to understand that there is a scientific purpose, and it has nothing to do about making you better or treating your disease as an individual. Dimension 2, study procedures. Making sure that people who participate know that these are not done for their individual benefit. Study procedures are done specifically to create knowledge. And so explaining that, because I get procedures done when I go to my pulmonologist, and I would have procedures done if I was participating in a clinical trial with her. So really explaining why those study procedures are being done, sort of emphasizing that scientific purpose, would help individual participants realize that they are not getting benefit. not designed for benefit, I should say. Uncertainty, emphasizing that there is a greater level of uncertainty about the risks and benefit than when a doctor offers standard medical care. And I think if it was worded someone like that, that people might have a better sense. And really explaining the difference there in terms of uncertainty, comparing clinical research to medical care, I think would be really ideal. Dimension 4, adherence to the protocol. Clinical trial activities require that individual participants follow the protocol as written. And compare that to the standard medical care which you get based on how you respond to the treatment. And that dimension 5, the clinician, so that physician that you're seeing is an investigator. And explaining the difference between the physician in healthcare setting providing individual treatment and the physicians in a clinical trial setting investigating the safety and efficacy of the treatment in the protocol. So here are some references. Of course, we always use our textbook, and then there is an attachment, this Henderson article about therapeutic misconception. Please let me know if you have questions, if you have any considerations about this, if you have any thoughts that are not discussed here. Please drop me an email or call me or Skype me. Thanks so much.